of holding a hearing on the threatening increase in opioid abuse. Drug abuse has become rampant in America and may be the worst the country has ever experienced. It's devastating families, degrading communities, and undermining several parts of our economy. For several states and districts represented by members of this committee, the problem is acute, as the map displayed shows. As Figure 1 indicates, the crisis has a regional character. My hometown of Columbus, Ohio is part of the crisis epicenter east of the Mississippi. Figure 2 shows the 2015 drug overdose death rates by state, which range from 40 per 100,000 in West Virginia to 6 per 100,000 in Nebraska. The states represented by the members of this committee are among the 10 highest rates, are highlighted in red, including my home state of Ohio, which ranks third. Drug markets, both legal and illegal, can be analyzed from the demand and the supply side. The exact reasons for the extent of drug abuse are not clear at this point. With respect to demand, a changing perception of pain as a health problem in the 1980s by the World Health Organization, in particular, laid the ground for more intensive treatment. The labor market and the economy can have a major impact on demand, although not necessarily in ways one might expect. Some research shows less substance abuse when unemployment increases, for instance, and while the prolonged downturns in labor market and economic conditions are associated with social, behavioral, and health problems, they do not necessarily affect all groups in the same way or to the same degree. All of society is vulnerable to this epidemic. It is compounding the economic distress that certain parts of the country and segments of the population already have been experiencing. Some areas of high employment tend to have higher rates of substance abuse. The Economic Innovation Group, a representative of which testified at our last hearing, the decline of economic opportunity, causes and consequences, developed an economic distress index consisting of several economic indicators. A national map, which is shown alongside the map of overdose deaths in the TV screens in Figure 3. The darker the red, the worse the distress. Striking correlations are visible, but it is also apparent from Figure 3 that some economically distressed areas are not experiencing high overdose death rates. From the supply side, the particular locations where new potent drugs initially happen to become most readily available and the path of geographic market expansion they took track a visible trail of destruction in Figures 1 and 3. Without question, new developments in the sourcing, cost production, potency, and retail delivery have moved the supply of both legal and illegal addictive drugs substantially to the right. Newly effective pain medication, OxyContin, introduced in the 1990s, had initially unacknowledged addictive qualities and was overprescribed. So-called black tar heroin, which Senator Heinrich and I were just talking about, more powerful and less expensive than other kinds, expanded its market share just as OxyContin was reduced in potency around the country. The prescription of drug expulsion started in the prescription drug explosion started in the Appalachian part of my state and spread to parts of Kentucky and West Virginia. Black tar heroin started in the Southwest and spread westward, but eventually also eastward, crossing the Mississippi in 1998. Illegally distributed variations and counterfeit forms of prescription drugs like fentanyl can be poisonous and kill a person even in small doses, some by mere contact with the skin, as Attorney General DeWine informed me earlier this year. We now face pure poisons masked as narcotics that are shipped across our borders. Senator Portman and I introduced the STOP Act, which aims to stop dangerous synthetic drugs from being shipped through our own postal service, keeping them out of the hands of drug traffickers in the United States. Half the members of this committee have signed on as co-sponsors in a bipartisan way, and we should continue to build support for this important legislation. But it would be a mistake to blame these drugs entirely for the rise in mortality that some groups and regions are suffering. There are other causes apparently emanating from long-term challenges in the composition of the economy and skills requirements. Determining cause and effect is obviously critical to reaching the right conclusions. Feedback effects often complicate causality and make a clear understanding of major causes that we are experiencing. For example, does a bad economy lead to drug abuse, or does drug abuse to a bad economy by lowering productivity, labor force participation, and social cohesion? We will hear about the economic decline of certain groups leading to despair and self-destructive behavior, of damage drug abuse causes individuals families, and communities in all segments of society, and the developments in the production and marketing of addictive drugs, which have made them the more dangerous, affordable, and available. I look forward to the statements of our witnesses. I will now yield to the ranking member who has another hearing. Mr. Heinrich is recognized.
Thank you, Chairman Tiberi, and thank you so much for holding this incredibly important and timely hearing. Thanks to our panel for being here today. Addiction to both heroin and prescription opioid pain relievers is a public health epidemic that is devastating families and communities across our nation. Every day, 91 Americans die from opioid overdose. Overprescription is partially responsible for this epidemic. Since 1999, the amount of prescription opioids sold in the U.S. nearly quadrupled, and so too has the number of overdose deaths from opioids. The economic costs of that addiction are incredible, totaling more than $80 billion in 2013 from increased healthcare costs, higher rates of incarceration, and lost productivity. New Mexicans know all too well the devastation that heroin and prescription opioids can wreak. For years, without adequate treatment resources, communities in New Mexico have suffered through some of the highest rates of opioid and heroin addiction and overdose deaths in the nation. Rio Arriba County has a drug overdose death rate of 81 per 100,000, 5 times the national rate. I am reminded of a young man named Josh from Espanola who I met at a roundtable I hosted last year in Rio Arriba County. At 14, Josh became addicted to prescription opioids. Over time, he moved to heroin. He stole from his family and his friends to maintain his growing addiction. Josh spent time in jail where he went through the pains of withdrawal. He even attempted suicide. Now in his 20s, Josh has turned his life around because he finally got access to treatment and services. For millions of Americans, proven substance use treatment is available because of 1, behavioral health parity laws, and 2, the Medicaid program. In New Mexico, Medicaid, called Centennial Care, is at the forefront of our fight against the opioid crisis, accounting for 30% of life-saving medication-assisted treatment payments for opioid and heroin addictions. At exactly the time that Congress should be giving states more tools to fight this epidemic, House Republicans passed a bill that would repeal Medicaid expansion, artificially cap the program, and shift the burden about who and what to cut onto individual states. More than 1 million people who have been able to secure treatment for substance abuse would lose their coverage. Repealing Medicaid expansion would cut about $4.5 billion from treatment for mental health and substance abuse. We cannot fight a public health crisis with grant dollars alone. Grant dollars run out, block grants lose their buying power over time, and private investment dollars, which are critical in this fight, won't come without certainty that the foundation is funded. Unfortunately, I will not be able to stay here to hear the important testimony of our witnesses today because of a hearing you may have heard about in the Intelligence Committee, but I will be leaving you in the very capable hands of my colleague, Senator Hassan. New Hampshire loses at least 1 person every day to a drug overdose. As governor, Senator Hassan used every tool at her disposal to fight the epidemic, including turning to the flexibility of the Medicaid program to gain ground in her state's fight. I'll let her tell you more, but I leave you with this. When a community faces a public health crisis, it's not long before a state turns to the Medicaid program to stem the tide. Thank you, Senator Hassan. I will turn over the rest of my time to you, and thank you, Chairman, for holding this critical hearing.
Well, thank you, Mr. Chairman and Ranking Member Heinrich. And to our witnesses today, thank you for being here as well. As I travel across my home state of New Hampshire, I hear from countless families and those on the front lines about how the heroin, fentanyl, and opioid crisis has devastated communities across our state. And I know that many of our colleagues have heard of the impacts in their states as well. I'm proud that during my time as governor, Republicans and Democrats in New Hampshire put our differences aside and came together to pass and reauthorize our state's bipartisan Medicaid expansion plan. Medicaid expansion is providing quality, affordable health coverage to more than 50,000 granite staters, including coverage for behavioral health and substance use disorder treatment. And experts have said it is the #1 tool we have to fight this crisis. We should be coming together here, just as we did in my home state, to support those on the front lines and help those who are struggling with addiction. And while members of both parties and the administration have discussed the severity of this crisis, we need these words to be matched by action. What we cannot do, however, is end Medicaid expansion and institute deep and irresponsible cuts to the traditional Medicaid program. This crisis is a public health and law enforcement issue, but it's also an economic one. I believe the investments in helping people recover are a far better use of our dollars than the long-term cost of addiction, both in terms of state budgets, but also in ensuring that individuals are healthy enough to contribute to our economy. I'm pleased that we are having this hearing today and very grateful to the chair for calling it, but we need to continue to hold hearings on how proposals made here in Washington would affect our ability to stem and ultimately reverse the tide of this epidemic. This is an issue that rises above partisanship, and this is the work that we need to be doing because the lives of our people in our states depend on it. I'm going to continue to work with my colleagues on solutions while standing firm against any policy that will pull us backwards. And with that, I thank you, and I look forward to hearing from our witnesses.
Thank you. Let me introduce our first witness. Richard G. Frank is the Margaret T. Morris Professor of Health Economics at the Department of Healthcare Policy at Harvard University Medical School. He has held several positions at the Department of Health and Human Services. Most recently, he served as the Assistant Secretary for Planning and Evaluation. Dr. Frank served as an editor for the Journal of Health Economics, is the recipient of awards from the Southern Economic Association, the American Public Health Association, and others, and he is co-author of the book, Better, but Not Well. Dr. Frank, you are recognized for 5 minutes. Turn on the microphone.
All right. Good morning, Chairman Tiberi and Senator Hassan. Thank you for inviting me to participate in this discussion of the opioid epidemic that's plaguing our nation. Just over 33,000 people died in 2015 from opioid overdoses. In the time I have with you today, I want to focus on the gap between the need for treatment and the receipt of care. In 2015, there was an estimated 2.66 million people with an opioid use disorder in the country. The illness is concentrated in the low-income population. That is, 51% of people with an opioid use disorder, or OUD, have incomes below 200% of the federal poverty line. Only 26% of the people with an OUD receive treatment for that disorder. That means that 1.97 million people who needed care did not get it. This is tragic because there are treatments that work. Medication-assisted treatment has been shown to be the most effective treatment for OUDs. They are combinations of pharmaceuticals, psychotherapy or counseling, and drug testing to monitor treatment adherence. Now, national survey data show that over half the people that did not get treatment because they either couldn't afford it or there were no providers available. Other reasons for not getting care were not being ready to stop using substances, stigma, and the denial of the problem. Now, policy tools are most amenable for addressing the affordability and availability reasons. I will focus on 3 areas that are helping to make the treatment gap smaller. They are Medicaid, private insurance, and federal grants. Medicaid covers about 34% of people with an OUD. Recent policy changes in Medicaid have bolstered Medicaid's impact. The combination of the Mental Health Parity and Addiction Equity Act that requires comparable coverage for mental health and substance abuse disorders with medical surgical care, the Medicaid expansions, and the essential health benefit that includes substance abuse treatment all have driven Medicaid to a growing role. Together, these provisions have resulted in large increases in the use of medication-assisted treatment. A number of states have been using Medicaid as a central part of their attack on the opioid epidemic. The state of Ohio recently reported substantial increases in access to care for people with opioid use disorder, And in Ohio, Medicaid now pays for nearly half of all the buprenorphine prescriptions in that state, which is one of the key drugs in medication-assisted treatment. Let me now turn to private insurance. Private insurance covers about 42% of people with an opioid use disorder. Recent changes there have bolstered the ability of private insurance to shrink the treatment gap. They are the Parity Act applied to private insurance, the essential health benefit provisions in the small group and individual market, and the availability of subsidized insurance policies for low income. In 2011, a survey of individual market insurers revealed that 34% of policies sold did not cover substance use disorders. Today, that is no longer the case. Finally, grants to states. The recently enacted 21st Century Cures Act appropriated $1 billion over 2 years that was intended to focus on closing the treatment gap by expanding capacity and expanding direct treatment. Just under $500 million of that money has been recently allocated to the states. Let me take a moment to put the Cures money into context using the state of Kentucky's experience. Kentucky is receiving a grant of about $10.5 million under Cures. That buys about 1,900 full-year treatments with medication-assisted treatment. Currently, Medicaid pays for 4,200 person years of treatment in Kentucky, and 3/4 of that is for the expansion population. That means if Medicaid cuts of the magnitude proposed occur, the Cures funds would likely not be used to expand capacity and treatment, but would instead backfill for Medicaid losses and wouldn't even be able to cover 2/3 of those. I now touch on availability. Since policy changes that I've described have begun, there's been a surge of new private money into this sector. There have been 170 private equity deals between 2012 and 2015, some as large as $100 million. These private investments are aimed at scaling up evidence-based practices, and the investment community acknowledges it is directly linked to the flow of new funds, both on the private and the public sides. So the last 10 years have set a platform for closing the treatment gap. The evidence suggests we are starting to see important expansions in both capacity and treatment that will pay dividends in the future. Turning back now doesn't make either economic sense and likely leads to tragic consequences. Thank you.
Thank you, Dr. Frank, for your testimony. Our next witness, Lisa Sacco, has been an analyst in crime policy with the Congressional Research Service since 2011. For the past 5 years with CRS, she has specialized and published reports on domestic drug enforcement, synthetic drugs, prescription drug abuse, and various other drug and crime policy issues. Prior to work at CRS, she received her doctorate in criminology and criminal justice from the University at Albany, held several drug-related research positions, and taught college courses on drugs and crime. Dr. Sacco, welcome. You're recognized for 5 minutes.
Thank you. Chairman Tiberi, Senator Hassan, and distinguished members of the committee, my name is Lisa Sacco, and I am a CRS crime policy analyst. Thank you very much for inviting me to speak with you. My testimony will focus on the scope of the supply of opioids in the United States. I will begin by stating 3 points from my written testimony that I will expand upon today. First, heroin, fentanyl, and controlled prescription drugs have been ranked as the most significant drug threats to the United States. While the reported availability of controlled prescription drugs has declined over the last several years, the reported availability of heroin and illicit fentanyl has increased. The availability of these drugs is a contributing factor to rising consumption. Second, the supply of opioids varies by region of the United States. Third, while the federal government has generally concentrated on reducing the supply of illicit drugs, federal drug control funding for supply reduction has remained relatively flat over the last several years, while funding for demand reduction has increased. While opioids have a long history in the U.S., this testimony focuses on the last several decades, as the market for these drugs has shifted a great deal. In the 1990s, availability of prescription opioids increased as a legitimate production of these drugs, and ensuing diversion from lawful use increased sharply. This continued into the early 2000s as users attained their prescription drugs through means such as doctor shopping, pill mills, the internet, and through family and friends. The federal government and state and local governments undertook a range of approaches to reduce the unlawful prescription drug supply, including diversion control through prescription drug monitoring programs, a crackdown on pill mills, the increased regulation of internet pharmacies in 2008, the reformulation of OxyContin in 2010, and the rescheduling of hydrocodone in 2014. Some experts have highlighted the connection between the crackdown on the unlawful supply of prescription drugs and the subsequent rise in heroin supply and abuse. Heroin is a cheaper alternative to prescription drugs that is often more accessible to some who are seeking an opioid high. While most users of prescription drugs will not go on to use heroin, accessibility and price are central factors cited by drug treatment patients in their decision to turn to heroin. The trajectory for heroin supply over the last several decades is much different compared to prescription opioids, but the stories of their supply are connected. In the late 1990s and early 2000s, white powder heroin produced in South America dominated the market east of the Mississippi River, and cheaper black tar and brown powder heroin produced in Mexico dominated the market west of the Mississippi. Price and purity varied considerably by region. In 2000, most of the heroin seized was from South America, while a smaller percentage was from Mexico. In recent years, this has dramatically changed. Over the last several years, heroin prices have declined, while purity, in particular the purity of Mexican heroin, has increased. Over 90% of the heroin seized is from Mexico, and a much smaller portion is from South America. Mexican traffickers dominate the U.S. heroin market because of their proximity to the U.S., their established transportation and distribution infrastructure, and their ability to satisfy U.S. heroin demand. Increases in Mexican heroin production have ensured a reliable supply of low-cost heroin, even as demand for these drugs has increased. Mexican traffickers have increased their production of white powder heroin and may be targeting those who abuse prescription opioids. Compounding the current opioid problem is the rise of non-pharmaceutical fentanyl on the black market. Fentanyl is often mixed with or sold as heroin, and it is 50 to 100 times more potent than heroin. Non-pharmaceutical fentanyl largely comes from China and is reportedly cheaper than the cost of heroin. The increased potency of synthetic fentanyl compounds is extremely dangerous, and law enforcement expect that the fentanyl market will continue to expand in the future as new fentanyl products attract additional users. The threat posed by opioids has increased since 2007, and the threat varies by region. In 2016, approximately 45% of law enforcement agencies that responded to the National Drug Threat Survey reported heroin as the greatest threat in their area. In contrast, 8% of respondents reported heroin as the greatest threat in 2007. Reports of heroin as the greatest threat are concentrated in the Northeast, Midwest, and Mid-Atlantic regions. Opioids are the main cause of drug overdose deaths. Reports indicate that increases in overdose deaths are most likely driven by fentanyl and heroin. The increasing availability of heroin and other opioids throughout the U.S. largely, but not entirely, corresponds to the increases in drug overdose deaths around the country. For example, New Hampshire ranks second in the country in drug overdose deaths, and they have reported high availability of heroin in the area. New Mexico and Utah, on the other hand, rank 8th and 9th respectively, but only 4.7% of survey respondents in the Southwest reported heroin as the greatest threat, and 22.6% reported high availability of heroin. This discrepancy may be explained by a number of factors, including the lethality of fentanyl. Historically, the federal government has concentrated on reducing the supply of illicit drugs, but in recent years, efforts to reduce the demand for these drugs have increased. Federal drug control dollars largely go toward addressing the supply side. However, federal drug control funding for supply reduction has remained relatively flat over the last several years, while funding for drug treatment and prevention has increased. Thank you.
Dr. Sacco, thank you for your testimony. It's an honor to introduce my Attorney General, Senator Portman's Attorney General, Mike DeWine, who has served as a state senator in Ohio, as a member of the United States House of Representatives, as a U.S. Senator, and now as Ohio's 50th Attorney General. He wrote Ohio's tough drunk driving law, has been a leading proponent for highway safety, and has advocated for victims of crime. He's assisted local law enforcement, advanced the use of DNA evidence for victims of crime, made efforts to assure prescriptions are safe, and worked tirelessly to fight the opioid epidemic in our state. I've known Mike for decades. I'm pleased you were able to come today to testify and give us your thoughts. You're recognized for 5 minutes.
Chairman Tiberi, Senator Hassan, and members of the committee, thank you so much for inviting me today. The most visible sign of opioid epidemic in Ohio, of course, is the number of deaths that we have. Last year, the official total was 8 per day. I think it was frankly more than that. Today, at least anecdotally, it's clear that that number is going up. But the cost is so much more. Every day in Ohio, we have babies who are born who are addicted. We don't know what the developmental cost for each of those children will be, what that will impact that particular child, but we know that many of them will, in fact, be impacted. We do know what the cost is. The cost in the hospital, neonatal intensive care unit, average child there, I think it spends about 14 days there at a very tremendous cost. Our foster care system is bursting at the seams. Our children's services are. 50% of all the foster care children who are in foster care are there because one or both parents are drug addicts. 70% of the infants that are in foster care are there because one or both parents are drug addicts. Our jails in Ohio are overflowing. We have more women in our jails and our prison system than we've ever had by far today. Our jails in Ohio, in our 88 counties, are really detox centers, something that they were not really designed for at all. Narcan, all responders carry Narcan, but as we have moved, and that is a great thing, and we've advocated for that, but as we move from pain meds to heroin to fentanyl to carfentanil, it takes more and more dosages. I had an officer tell me the other day that it took 12 different dosages to bring someone back to life. But the number, the big cost that we really, I think it's much more difficult to determine, but it's huge, absolutely huge, is the number of people who are in Ohio who cannot pass a drug test and therefore cannot have a number of jobs. You could never hire someone who can't pass a drug test to be around machinery, never hire someone to even be in charge of the local McDonald's or the Burger King. You cannot have someone to drive a truck. The missed opportunities, the fact that these people are not living up to their God-given potential with the tremendous impact it has on their own family, but also impact it has on the state of Ohio, is just absolutely huge. I do kind of a little quiz when I talk to employers, and I say, do you drug test? And if they say, yes, I drug test, I say, well, what percentage of the people who come in here and you tell them they have to take a drug test leave before they take the drug test? And then add to that the percentage of people who come in here and are so arrogant or stupid, or both, that they take the test and fail it. The average that comes back when you put those two numbers together almost every single time is 40%. It's not scientific, it's anecdotal, but it tells us, I think, some of the great loss we have. What do we do about it? We start, I think, with the premise that most people who are addicted today to heroin, fentanyl, et cetera, started with pain meds. The first thing that we did is we took the licenses of over 100 doctors in the state of Ohio. These were bad people. These were drug dealers. They needed to go away. But what remains is a lot of good doctors who are still, frankly, influenced by a culture that we believe, the evidence shows, was caused by the drug companies purposely, to indicate that someone who has long-time chronic pain that is not terminal, that they are an appropriate candidate for pain meds. These doctors still, I think some believe, that pain meds are appropriate for that circumstance. I think that is a problem. We're slowly changing that culture, Mr. Chairman, and I think making improvement. Local communities must own the problem. There must be an admission that there is, in fact, a problem. What follows that should be an inventory. What are the assets that we have? What are the challenges that we face? And then all the community has to go together. The business community, the law enforcement, the educators, and the churches. One of the things we have emphasized in our office is the faith-based community needs to be involved. Another thing that's happening in Ohio, Mr. Chairman, is law enforcement is doing something it never did before, and that is helping get people into treatment. Just amazing stories. Senator Tharp, or excuse me, I gave him an increase in title. But, Sheriff Tharp in Lucas County does an amazing job. They go to the emergency room. They take people from the emergency room if they're ready for treatment, and they work with them and get them into treatment. Let me talk about two other things, if I could, Mr. Chairman, and I'll conclude. I believe that we need to move to a K through 12 every year, talking to kids in school about this problem. I think it should be repetitive, comprehensive, and school-based, and it must be age-appropriate. You're not going to talk to kindergarten kids about heroin, but you will talk to them about maybe the good choices and health. And if you see a pill, don't pick that up. I was on Reagan's National Commission on Drug-Free Schools. Every expert who came in said you have to start in kindergarten, you have to do something every single year. We had a study commission that put this out, and I would make this available to anyone who is watching this or any members of the committee. It's only 23 or 4 pages. We have mailed this to every superintendent in the state. Finally, Mr. Chairman, I think in this country we need to do something. And I think it really needs to be on a national scale. We have to change the culture. When I was a county prosecuting attorney in the 1970s, heroin was something that even people who were doing drugs, most people wouldn't touch heroin. There's a psychological barrier there. That barrier is simply gone today and no longer exists. I think what we need is a media blitz, a social media blitz on TV that is aimed at really two groups of people. One are kids and one are parents and adults. Get all the experts together. I'm not an expert in this, but put them together, put the best media people we can put together, and let's try to change the culture, because the irony is that as we have changed the culture in regard to tobacco, it took a long time, we've gone in the right direction. In regard to opiates, we've gone in absolutely the opposite direction. We can turn this around. Thank you, Mr. Chairman.
Thank you. Our last witness is Professor Sir Angus Deaton, who is a senior scholar and Dwight D. Eisenhower Professor of Economics and International Affairs Emeritus at Princeton University's Woodrow Wilson School. He is also Presidential Professor of Economics at the University of Southern California. He is a member of the National Academy of Sciences, the American Philosophical Society, and an honorary fellow of the Royal Society of Edinburgh. He was president of the American Economic Association in 2009. In 2015, he received the Nobel Prize in Economic Sciences. In 2016, he was knighted by Prince William at a Buckingham Palace ceremony. Thank you for joining us today, Professor Sir Angus Deaton. You're recognized for 5 minutes.
Thank you, Chairman Tiberi, Senator Hassan, and the other members of the committee for holding this hearing on economics and the opioid crisis. Deaths from legal and illegal drugs are contributing to an almost unprecedented increase in overall mortality among middle-aged white non-Hispanics. A century of mortality decline came to a halt at the end of the 20th century, and mortality rates for this mid-aged group were higher in 2015 than in 1998. Driven by these developments, life expectancy at birth, a key indicator of how well a society is doing, fell for white non-Hispanics from 2013 to 2014, and for the whole population of the United States from 2014 to 2015. Opioids are a big part of this story. Supplies of opioids have stoked and maintained the epidemic. Selling heroin is profitable and illegal. Selling prescription drugs is profitable and legal. Pharmaceutical companies have made billions of dollars in profits on prescription opioids. Opioids have a legitimate, if limited, role in treating pain, but perhaps it would have been better had they never been approved. Physicians are far from infallible in detecting which patients are likely to become addicted, and once patients are addicted, treatment is difficult and often unsuccessful. My work with Ann Case has examined opioid deaths as part of an epidemic of mortality, what we call deaths of despair. These are suicides, deaths from alcoholic liver disease, and accidental overdoses from legal and illegal drugs. The opioid deaths are the largest component. In 2015, for white non-Hispanic men and women aged 50 to 54 without a college degree, who are much more seriously at risk than those with a college degree, deaths of despair are around 110 per 100,000, of which 50 are accidental overdoses, 30 are suicides, and 30 are from alcoholic liver disease and cirrhosis. There's recently been a turn-up in mortality from heart disease after many years of decline, and if obesity is the cause, some of these deaths might be deaths of despair, which would put a total at levels approaching deaths from cancer or from heart disease, the two major killers in midlife. Figure 1 shows the all-cause mortality rate for white non-Hispanics, the red line aged 45 to 54, together with mortality rates for selected comparison countries. The mortality rates in midlife in other countries continue to decline at the rates that prevailed in the United States before 1998. Americans are killing themselves by drinking, by accidentally overdosing, by overeating, or more quickly and more straightforwardly by committing suicide. Deaths of despair have risen in parallel for men and women. See Figure 2. Such deaths, like all suicides, are lower for women than for men, but the increases have marched in lockstep. The key distinction here is not between men and women, but rather between those with and without a college degree. Deaths of despair cannot be explained by the economy. They were increasing before the Great Recession and continued to increase afterwards. We think of all of these deaths as suicides of a kind, and suicides respond more to prolonged economic conditions and to the associated social dysfunctions and loss of meaning in the interconnected worlds of work and family life. Workers who entered the labor market before the early 70s, even without a college degree, could find good jobs in manufacturing, jobs that came with benefits and on-the-job training, that could be expected to last, and that brought regular increases in earnings and a road to middle-class prosperity. Not so today. With fewer good jobs, there has been a decline in marriage rates, though couples often cohabit and have children out of wedlock. Those cohabiting relationships are less stable than marriages, so that many fathers do not live with or even know their children, and many children have lived with several fathers by their early teens, fathers in quotes. Heavy drinking, overeating, social isolation, drugs, and suicide are plausible outcomes of these processes that have cumulatively undermined the meaning of life for white working-class people. Within this context, we tend to see the opioid epidemic as accelerants, as something that's poured fuel on the fire of something that was already very bad already. Thank you very much.
Well, thank you all for your testimony today. And before I begin answering my questions, just two notes. In the spirit of bipartisanship, I allowed the Democratic witness to go first. I hope that is noted as we move forward and continue bipartisanship on this panel. And I allowed the former senator and former member of this body, House, a few extra minutes out of professional courtesy. With that, Mr. Attorney General, you hit on something in your testimony that I hear about all the time in the 7 counties in my district, whether it be urban, suburban, rural, or small town, and that is the impact that this is having on the economy. Employers who are saying, you know, I've got 3 positions open and I can't find anybody to fill the position who can pass a drug test. From your perspective and all the work that you've done in this area, whether it's heroin or opioids or whatever type of drug abuse, where do you see in our state the problem being the worst in terms of the economic conditions? Is it in places that have historically been left behind? Does geography not make a difference? Can you give us your thoughts on it?
Mr. Chairman, I think if we analyze this, what is different about this drug problem that we have is how pervasive it is. It is absolutely everywhere. It is in our smallest communities, it's in our cities, it's in our most affluent suburbs. I think if you go back historically, you could trace the beginnings of this to Southern Ohio, our Appalachian counties, in regard to the pain med problem. We think that most of the addiction, although some people may start on heroin, most people become addicted to the pain meds and they move to the heroin because at some point they can't get the pain med anymore, and because heroin is so cheap. They move then from possibly to fentanyl and carfentanil. So if you go back 10 years, where you would see where the biggest problem would be is in Southern Ohio with the pain med problem. I'm not a sociologist. I'm not sure I can guess, but I don't have a great deal of expertise in this area at all. But it starts with that, but it is absolutely everywhere. And part of the challenge, I think, always, as you look at this problem, and I know that some states are at a different stage than we are. We're well down the path. What I would, suggest is the biggest challenge you have is getting people to understand that this is a problem in their community. And for the last 5 years, every interview I've done on this, I've looked into the camera, if it's a TV camera, and I've said, if you're watching this, you have an opiate problem. You have a drug problem in your community.
So just one follow-up. You mentioned this demand problem and talking to kids as early as kindergarten. How about the supply problem? Is there any way to deal with that? You said you see it everywhere in our state, law enforcement seeing it everywhere. Any thoughts on the supply issue?
Well, of course, you're talking to somebody who is a county prosecuting attorney, and what we do in the Attorney General's office is assist local law enforcement. So we always look first to the law enforcement problem. And what we did 5 years ago is we created what we called a law enforcement heroin unit out of BCI. And I can't really talk in public about exactly what we do, but we will go in and help the local sheriff or the local prosecutor or the local police. Once they've already started their drug investigation, we will help them take it to a higher level and to get the bigger fish and the bigger drug dealers. That remains an essential part of what we do. I've talked to the Attorney General of the United States about cooperation with information coming off the border. And that is a work in progress so that we get real-time information coming off the border back into Ohio. So we do work with our federal partners and the FBI, Drug Enforcement Administration, and we have a very close and good working relationship with them. So law enforcement is a key component part, but we're not going to arrest our way out of this problem. We have to deal with it holistically, which is do a better job in regard to treatment and getting people into treatment and keeping them in treatment, and we have to do a better job, a much better job with prevention, where I think is the most opportunity. If you look at this from the long run, where are we going to be in 10 years, 15 years, or 20 years? Start today in kindergarten, and very few schools are doing this.
Thank you. Professor Deaton, you talked about the deaths of despair, the economic conditions that cause it. Are those economic conditions, from your perspective, getting worse? Or are they trending better? Or is it geographically different?
I think they've gotten somewhat better in the short run, but I don't think this is being a short-run problem. I think this is a deep problem to do with, what people who don't have a university degree are going to do with their lives. And the world that they used to inhabit is a world that's broken. And I think the things that gave meaning to their lives, the steady jobs, are really not there anymore. And I am not particularly optimistic. I don't think it's a good idea for everyone to go to college. I mean, I just think maybe things like apprenticeships, maybe a new way of thinking about that world of work really would help. I should say, though, that I de-emphasize the opioids because that was my shtick here, but I think doing something about the opioids in some sense is the easy part of this, though God knows it's hard enough, and that we really have to do that. And we really have to change this culture of doctors that believes that pain should be treated with heroin, essentially, which is something we never used to do.
Thank you, Professor. Appreciate that. My time has expired. Ms. Hassan is recognized for 5 minutes.
Thank you very much, Mr. Chair. And again, thank you all for your testimony. Dr. Frank, Medicaid has served as a lifeline for states that have been hit hardest by the opioid epidemic. And experts have said it's the #1 tool we have in combating this crisis. As a former governor, I certainly understand how critical it has been in ensuring that Granite Staters struggling with addiction have access to treatment and recovery services. So I'm obviously concerned that the Republican bill that passed out of the House in April would fundamentally change the Medicaid program as we know it. Instead of being a guaranteed benefit for states and their residents, the per capita cap in the plan would result in massive cuts that would set limits on federal contributions regardless of the need for care and services. That will mean less buying power over time and will leave states with far fewer resources to provide services to their citizens. Could you address how a per capita cap approach to Medicaid would impact a state's ability to fight this epidemic and or future public health emergencies?
Sure, thank you for that question. The per capita cap essentially is set up so that it locks in 2016 per capita spending patterns and then inflates them forward at what the Congressional Budget Office predicts is about 3.7%, which is the expected consumer price medical component. And so what that does is it allows you to keep up with general inflation based on the 2016 patterns of treatment. Now, as we know, mortality from opioids is growing at 15% a year. Hospital admissions at about 6%. Drug treatments for opioid addiction is growing at 10 to 12% a year. And so what happens is when you have a per capita cap that's based on that 2016 pattern, and new things happen or old things grow faster, you start to fall behind very quickly.
Thank you. Ms. Sacco, we know, to your point, that we need to attack the supply side of this epidemic, something that we've been working on in New Hampshire, and we know how law enforcement plays a critical role in cutting off the supply side of illegal opioids and other drugs into our communities. But in New Hampshire, our law enforcement officials will be the first to say, just as Attorney General DeWine just did, that we can't arrest our way out of this problem. I still remember the colonel of my state police calling me when I was a new governor saying, could I testify in favor of Medicaid expansion because we need it. So we need to treat this as the public health crisis that it is and focus on addressing the demand side, which means having an effective public health response that could be more cost efficient and effective. Oftentimes, medication-assisted treatment is less costly than simply incarcerating someone with a substance use disorder, not to mention being more effective at addressing the problem and reducing recidivism. Dr. Sacco, do you agree that the opioid epidemic requires both public health and law enforcement responses to addressing the crisis? Do you agree with the law enforcement officials in my state and the Attorney General here that we can't simply arrest our way out of the problem?
If you are, Senator Hassan, if you are seeking to address both the supply and the demand, then yes, it would be a comprehensive approach. Law enforcement is a strictly supply order, but yes, right now the response seems to be one that is comprehensive.
Okay. And would you agree that working on expanding prevention, treatment, and recovery programs, including Medicaid, is important to helping address the entire crisis?
CRS does not take a position on the advisability of that. I'm sorry.
Okay. Dr. Frank, proposals coming out of the House would undermine the essential health benefits provision of the ACA that requires the coverage of substance use disorder services. CBO says that could increase out-of-pocket costs by thousands of dollars. Do you believe eliminating substance use treatment places a barrier to access to care for people struggling with substance use disorders?
Absolutely. We've seen in the states, for example, that expanded Medicaid and in states where there's been dramatic decreases in the uninsured rate from private insurance, we see those are the states that have responded most strongly with medication-assisted treatment in serving people with opioid use disorders.
Thank you very much, and I see my time is up.
The gentleman from Minnesota is recognized for 5 minutes.
Thank you, Mr. Chairman, for holding this hearing on such an important issue that is having such a significant impact on communities across the country. This is certainly, as has been mentioned in the testimony, a problem that is everywhere. And unfortunately, Minnesota has not been able to escape the devastating effects, economic and otherwise, of opioid addiction and the opioid crisis. Just last month, I spoke to a mother from Maple Grove, Minnesota, whose son bought acrylfentanyl, an analog of fentanyl, online. He consumed it, and he died. And it goes without saying that she was devastated by the loss of her son. But she was also devastated by the ease with which he was able to purchase the opioid online. While it may not be within the scope of today's hearing or committee, there is certainly a role for Congress to play to ensure that opioids are not so easily accessible. Unfortunately, Minnesota was also the home to a much higher profile opioid overdose case on April 21st of last year. Prince, one of the most successful pop artists of all time, passed away in Chanhassen after taking fentanyl. My point is that this is a problem that affects many different types of people, old and young, rich and poor, your neighbor down the street, as well as an international celebrity. And while it is important that we understand and address the physical and emotional effects of the opioid crisis on Americans, there is also value in coming to grips with the economic toll it is taking on the country as well, which is why I appreciate having such a great panel of witnesses that are here with us today. Let me just start with a few questions. Mr. DeWine, the synthetic opiate fentanyl is 100 times more potent than morphine. And then carfentanil is similar, but is 10,000 times as strong as morphine, and then was developed for tranquilizing elephants and other large mammals. In just the past few years, fentanyl deaths have skyrocketed. In Ohio, as you've mentioned, averaged, I think, 4 fentanyl deaths per year from 2007 to 2011. And in 2015, there were 1,155 fentanyl overdose deaths. Do you have insight into the reasons for this development in Ohio in particular, or are there parallels or lessons that can be drawn for other states?
Congressman Paulson, thank you for the question. You know, carfentanil is so dangerous, and fentanyl as well, but carfentanil certainly much more. That about a year ago, we sent a bulletin out to every chief of police and every sheriff in the state, telling him and her and their officers, men and women of these departments, don't field test drugs anymore. Stop it. Don't touch it. We had an experience in Ohio within the last month or so where an officer overdosed literally because he was in the presence of this, and somehow it got into his system. So it is highly dangerous. We believe a couple things are happening. We believe that the fentanyl is coming in primarily from China, although certainly some could be actually being made in Ohio, but we think mostly it's coming in. I know Senator Portman has been directly involved in that concern, and the members of the House and the Senate have been. I think you see the drug dealers, they're great marketers. I mean, it's amazing. I mean, this whole system is all about customer service, and it's all about delivery. I mean, I tell people that if you look at heroin, you know, the Mexican drug cartels have developed a perfect business model. You know, they grow the poppies in Mexico, they ship it across our southern border into Ohio. They control it down to the street level. At some point, they may sell it off to the local dealers. And then what kicks in is what I call a pizza delivery system. You pick up the phone, you call, and they'll deliver it. And you get it in half an hour, and you're going to get cheap. But they get you started. And I'm told, I'm not a medical expert, but I'm told that the ratio between an early stage heroin addict and maybe a late stage heroin addict, the amount taken could be as high as 100 to 1. So what starts as a $10 a day habit may go to a $1,000 a day habit. They're always chasing a high. And what the reason I think you get to fentanyl is two things. One, it's easier for the drug dealers to get, and it's cheaper for them, and they can make more money on it. And number two, it's a way to broadcast that you know, this is something different. This is a better high. The irony is that when we get a situation where 5, 6, 7 people die in a weekend in some city in Ohio, obviously because we're on to fentanyl or we're on to carfentanil, and it's a different potency or something's there, the demand appears to go up. And so we worry, you know, we put the bulletin out and local law enforcement says, look, be very, very careful. What we worry about is that we're just encouraging people to go seek a higher high. It's just, nothing makes sense about this. And, you know, I think it's clear people's brains are being altered, and they're, you know, the person who is buying it is not looking at it rationally or the way you and I would be looking at it today, not being addicts.
Thank you, Mr. Chairman. Thank you.
Mr. Delaney is recognized for 5 minutes.
Thank you, Mr. Chairman. I want to thank you for holding this hearing on obviously a very important issue that affects all of our districts. As Mr. DeWine said, this is in every community in the country, And the fact you've assembled such a terrific group of witnesses, I'm grateful for that. And in particular, I want to thank Mr. DeWine for what he's doing in holding the pharmaceutical industry accountable. You'll make them pay like other people will, and that won't solve the problem, but it's the right thing to do, and it'll send a message that we're going to start thinking about these things differently. And we believe in a capitalistic system in this country, I certainly do, but we want it to be just at some level. And efforts like what you're doing will help make that happen. And it's fairly obvious what we need to do, and the witnesses have very eloquently covered it here today. Whether we have the commitment and conviction to do it is a question, but the steps that Mr. DeWine is taking are obviously incredibly important. Making sure we manage ourselves through this situation by having the healthcare system in place that can support the people afflicted by this, and I associate myself with the senator from New Hampshire and her eloquent comments about the importance of Medicaid. Dr. Frank, your comments were very encouraging when you talked about how private investment sees this as effectively a very large business opportunity, and they're putting a lot of money and resources against it, and there'll be a lot of innovation. So the same forces of capitalism that caused the problem here hopefully will be directed towards solving the problem. And so if we're optimistic, perhaps we see a path out of the opioid crisis. But Professor Deaton, your comments were the most sobering in many ways. These deaths of despair are a manifestation of something that's going on in our society, something very broad and very significant and vexing in terms of how we deal with it. You know, we've allowed globalization and technological innovation to occur, which have been extraordinarily positive for the state of humankind, but they've been very negative, very, very negative for certain communities in particular who weren't prepared for it. It happened too fast. And it's been negative for pockets, really, in every community. And how we confront that and the isolation, the lack of security that human beings have. You touched on it. They're not getting married. This opioid situation was really kind of the perfect storm or the confluence of events, almost like a match to fire based on that. So they're not moving. There's no mobility. These people are frozen. They lack security. They're not engaging in society the way Americans have historically engaged. And the cost of doing nothing against this is obviously not nothing. And so as an economist, how do you think about how we should approach this? Because it seems to me a transformative investment is required in these communities if we're actually going to jumpstart them and the citizens of these communities out of the condition that they're in right now, which will obviously be very expensive. But how do you think about that in terms of not doing something?
Thank you, Representative Delaney. I wish I knew the answer to that question. I think globalization has been an issue. I think automation, in some ways, is more of a threat to many of those jobs. There's not been much of a decline. In fact, in most industries, there's been a substantial increase in American manufacturing output, but the jobs are not there anymore because we don't need the labor to do that. I don't know. I mean, I think, you know, you saw the slides I showed. This is not happening in Europe. Right. And Europe is facing the same challenges. Globalization is happening to Europe. The pressure on jobs is the same in Europe. And one of our research topics, and I don't know the answer, I mean, my friends on the left tend to say Europe has a much better social safety net than we do. One of the policies that people talk about is mothers, children get state allowances on a regular basis, which stops mothers having to shop around for men all the time. Yeah. And this sort of merry-go-round of marriage is slowed down. But there's a lot of dysfunctions going on.
And what is the cost to us if we don't solve this problem?
Well, I think the opioid problem will get solved.
Yeah, putting aside the opioid problem, but the more structural problem that you identified.
Well, I mean, the cost to us depends on what the counterfactual is. I mean, do you actually think we can do something about this? And what is that something that we can do? And I certainly think we need to think through all possibilities and look at some of the things that are happening in Europe. The German apprenticeship system seems to really hold people together in a way that doesn't happen in this country, for instance. I know a lot of employers are upset about the labor force coming out of college or below is not trained for what they want, and some sort of apprenticeship system may help that. But I don't have any surefire solution to solve this. Thank you.
Thank you, sir.
Gentleman from Arizona is recognized for 5 minutes.
Thank you, Mr. Chairman. And have you ever had one of those evenings where you can't sleep, so you're up reading, about what's, and I read over all of here, and I want to find an elegant way to say this, because being from Arizona, a border state, we at least document a couple lost lives every single day in Arizona. But in not talking some of the book from my friends on the left, I'd love to actually take a step backwards, because there's things in the data. I actually built some charts off Dr. Frank's information, and in some ways, I couldn't make parts of your argument work with the chart, on saying during time of Medicaid expansion, my numbers are going up still double digits. So is there any data sets, if we were just to wipe our minds clean of our partisan angst and say, give me something to look at that would help us do policy of, is it an economic driver? Is it the synthetics that are so small they're easy to transport and ship? Is it border? Is it demographics of the aging of my society? If I were to try to build a number of charts and say, here's my inflection, here's where we're going to build our policy goal, please, someone help me build what that policy is. And I was going to go to Dr. Sacco. You live in this. You've been doing this for years. You had some real interesting stuff in your write-up. Where would you take us if you were building the policy?
I think some things have already started, as you're more than aware. In China, as you know, most of the fentanyl is coming from China. China recently scheduled for fentanyl products. And so at this point, this was only in March. This remains to be seen whether this has an effect on what's coming over from China. There's, as I think I mentioned, there's increased production of heroin in Mexico and declining production in South America. It may be worthwhile to take a look at reducing the poppies in Mexico.
But my fear is that's not my global solution. I'm just now chasing a substitution of product. So.
Oh no, I'm saying this is. I'm speaking to the supply side today. Absolutely, you should speak to my colleagues about the demand.
Dr. Frank, you have something to this.
Yeah, in a sense, you're asking. There's the sort of growth problem, and there's the levels problem. And on the levels problem, if we cut the number of opioid prescriptions in this country by 90%, we would still be the largest consumer of opioids in the world.
So in that model, one of the first things you would do is, let's say we could wave a wand and the elimination of prescription opioids.
No, I think it's more making sure that all our providers are trained in the best possible practices, because I don't think we can ignore the pain problem. We have a real pain problem in this country.
Okay.
So
well,
I think that we need to sort of balance the two, and so far we've tipped the scale too far the other way.
But just from a junior standpoint, just looking at what the chemical compounds were in the synthetics, it's not that hard to make. I mean, the precursors. So I'm still not hearing a global professor. From an economist standpoint, what's my global solution?
I wish I knew. I'm more skeptical than Dr. Frank is about treatment. I think somehow we have to choke back the supply. I mean, it's interesting to look back to 30 years ago, what happened with the crack epidemic, which devastated a different set of communities. And I think the best—
Is there a parallel we can learn from that?
Well, I think the communities dealt with it in the end, and it became sufficiently pervasive that the communities, it's what Attorney General DeWine was talking about. We can educate the communities to the point where this becomes completely intolerable. And I think we need to be able to do that. And the schools would be a place, but the police are working on this. And it's still true that not all that many people know about it. And I think the doctors really have to be choked back. I do believe that there is a genuine pain epidemic in this country. I don't know how much of it was stoked by opioids, how much of it was stoked by the pharma companies, but I think there's something else there, and we have no idea how to treat that.
Thank you, Professor. Mr. Chairman, I'm genuinely grown to believe this is one of those we do everything, from economic to information to restrictions to access to it may be there's not a magic bullet. It needs to be an armory. Thank you, Mr. Chairman.
The gentlelady from Minnesota is recognized for 5 minutes.
Thank you very much. Thank you to all of you. I see Senator Portman is here, and along with Senator Hassan. We've been working hard on these issues for many years. We passed our bill last year, which of course set the framework out. And I really look at this as 3 different things. One is trying to stop people from being addicted in the first place. And that's things like getting the drugs out of the medicine cabinet, changing doctor prescribing practices, and doing something on stopping the huge amount of drugs out there that are legal but aren't being used in the right way. The second is treatment, of course, and the third is then going after the illegal drugs. And we're going to see more use of that as we hopefully can reduce the number of legal drugs that are going out and getting people hooked. So along those lines, Attorney General, I was really interested and happy to see that you brought that lawsuit against 5 opioid manufacturers, alleging that the drug companies engage in fraudulent, deceptive marketing campaigns about the risks and benefits of these opioids. I know there was a settlement in West Virginia on a similar case. The idea is the money, of course, goes into treatment, and it seems to me that the people responsible for marketing these drugs should pay for the human costs of what has happened here. So could you talk about what you can about that lawsuit and how you think it could be replicated across the country, because all the education we're doing isn't getting us the money we need for treatment, and it's not stopping the bad guys from getting people hooked. And by that, I don't mean illegal drugs.
Senator, thank you for the question. You know, I made it plain last week when I held a press conference that when I explained what we were doing and why we were doing it, one thing I said to my Ohio citizens is, this is not a substitute for the hard work at the local level. I am convinced that the work has to be done at the local level. I started seeing 5 or 6 years ago when we were dealing primarily with the pain med problem, that the communities that were making the most progress were communities where it had gotten so bad, they just got sick of it. And it was usually a grassroots effort led by a mom, sometimes a dad, but it's usually a mom. And they just go and they try to transform the culture in that community.
Do you think a lawsuit, which I believe, like in the tobacco industry, the lawsuits actually got the information out there, and and it stopped people from doing bad things?
Yeah, let me get to the second part, Senator. Thank you very much. We believe this lawsuit is a fair lawsuit. We believe that what the evidence will simply show is that the pharmaceutical companies, beginning in the late 90s, tried to change the culture. The culture historically had been for pain meds that they're used for acute pain. You have your tooth taken out, you take it for a day, 2 days, 3 days. Or it's used at the other end of life, at the end of life when you have someone who is terminally ill. What the pharmaceutical companies did is they tried to convince doctors, and did convince doctors, that, hey, it was just okay to use it for a third purpose. And that third purpose was for pain that it goes on day after day after day, but is not terminal. And they did it. And they were very successful in doing it. In response to your question, one of the things that I would like to see these companies do, and they can do it tomorrow and start, with lawsuit or no lawsuit, is to spend some money to change the culture back to where the culture should be, which is, several of you have said, is somewhere in the middle.
Thank you. And we also have a bill with Senator Manchin that would put a fee on some of these drugs and have, again, that go per milligram, have that go to treatment. And so I guess, Professor Deaton, congratulations on your good work. Could you comment on what the Attorney General's has done here, which I think is commendable, and how sometimes lawsuits can change the economic situation if companies are afraid of getting sued, that it's not just public shaming, but actually out of their bottom line, that can make a difference in how they behave.
Thank you, Senator. Yes, I think it can make a difference. I mean, I don't have the figures, but the LA Times reported that the family that owned OxyContin had made $51 billion from it by the middle of last year. This is a time where that drug is killing large numbers of people. And I think, you know, we ought to make it clear that this cannot be tolerated. I also agree with the Attorney General that the local effort is where the culture will be changed, but we don't need pharma companies trying to push doctors to prescribe addictive opioids for lower back pain.
Right. It just makes me cry when you see all these rehab people and small town mayors and cops are all trying to do the right thing, and then these people are getting a different message either on TV or when they go into the doctor's office, and it just has to change. Thank you.
Thank you. It's an honor to introduce my senator, who's been a national leader, as you know, Attorney General, on this issue, and talked to me last session of Congress about introducing a bill, which I did, that you've been a leader on, the STOP Act, deals with this issue of fentanyl coming in from China. Mr. Portman, you're recognized for 5 minutes.
Thank you, Chairman Tiberi, and thanks for your leadership all along, and more recently taking the lead on the STOP Act. I think you have 123 co-sponsors, I'm told, and thanks to CRS for helping us with that legislation, and to Mike DeWine for his help, both as the top law enforcement official in the state of Ohio, who cares a lot about the supply side and keeping this poison out of our communities, but also someone who gets it, which is this is ultimately going to be solved through a comprehensive approach focusing on the local community. And I was in this room 20 years ago as a House member trying to get legislation through called the Drug-Free Communities Act, which is now a law that has helped spawn over 2,000 community coalitions. Our whole focus was local, including one that I founded and chaired in Cincinnati, and yet here we are. The worst drug crisis in our history, by any measure, as bad as it's been in the past. And I think what we've learned today from this terrific panel of experts and also from some of our colleagues, including Congressman Schweikert, is that, Mr. Chairman, the comprehensive approach that you've been advocating is the only way, and it has to be at every angle, and it has to include much more aggressive prevention and education efforts. And Senator Klobuchar and I are co-sponsors and authors of this STOP Act. Senator Hassan is one of our original 4 co-sponsors, by the way, is here too. But she also was one of the original Klobuchar, me, White House, and others pushed this comprehensive approach in the Comprehensive Addiction and Recovery Act, called comprehensive, but it includes a big component of education and prevention is yet to be implemented, including a national awareness campaign on making this connection, as Attorney General DeWine has made well today, between prescription drugs and heroin, fentanyl, and other opioids. And I think Professor Deaton's right. A lot of people don't make that connection because they're not aware of the information. So when you go to a doctor and someone who you trust prescribes opioid pain medication and says, here's 60 Percocets, take this for this oral surgery you've had, you trust that doctor and you do that. And for some people, there is obviously a change in their brain, which is a disease, which is called addiction. And that is something that we can do as part of this. And there are other aspects of the CARA legislation that need to be implemented. And I've urged the Obama administration, as I'm now urging the Trump administration, to move quickly on implementing these things in the face of this crisis. A couple of quick questions. One, to Senator DeWine, and again, as the Chief Law Enforcement Officer in our state, you know much better than I what's going on. But I just got an email yesterday from the coroner in Cuyahoga County, Chief Medical Officer Dr. Gilson, who was here testifying, by the week before last over in the Senate, and he reported to me that 43 people have died in Cleveland in the couple of weeks since Memorial Day. He believes it's fentanyl-driven. By the way, this is in contrast even to the horrible rate of overdoses and deaths last year of being, more in the 20 to 30 range. We're now, even this year, in April it was under 40, now in 2 weeks over 40. So can you talk a little about what's happened in Ohio and maybe specifically what I'm hearing back home, which is this notion, to Professor Deaton's point about who's being affected, that this is now being spread into the African American community more with regard to these evil traffickers sprinkling fentanyl in cocaine and starting a whole other series of addictions. If you could just speak to that a little bit, I'd appreciate it.
Well, Senator, thank you very much for the question. Thank you for the great work that you've done. You've been a real leader in this field. You know, I think there is a natural progression, which starts generally with the pain med. 35-year-old, 40-year-old, blue-collar male, hurts his back, is prescribed pain meds, becomes addicted to it, and everything goes downhill from then. He moves over to the heroin because it's cheaper, it's maybe more available. And then the other thing that you have, as you point out, going on is fentanyl now. And the fentanyl, we're finding fentanyl a lot more now, more and more and less heroin. It used to be it was sprinkled in with it. One of the things that we're seeing in our crime lab is that these cases are much more complex and take longer to do because instead of it being all heroin or all fentanyl, it's all mixed up, and so it slows that down. But I go back to something I said a moment ago. I think it is a marketing technique, and these people who are selling this stuff and who are killing people, they're good marketers, and it's all about service, and it's all about getting the best high, and part of the marketing is, hey, we got something new. And that something new may in fact be fentanyl. As far as it moving more into the African-American community, I don't have any data on that, but sure, it would appear that anecdotally would appear that it's getting pushed out. And you know, as I look at this problem from maybe a big picture point of view, sometimes people will ask me, you know, Mike, what keeps you awake at night as the Attorney General? My quick answer is the opiate problem. I think it's a bigger problem that's been alluded to by several people here today. The opiate problem is a subset of a bigger problem. The bigger problem is that we have a large number of people in Ohio and other states who are not living up, for many reasons, to their God-given potential. And we've got a problem with people not having the right skills. And that does impact this some. Not in every case. I mean, we're seeing a lot of middle-class people who everything would appear to be going fine in their life, but there's something going on there that it causes that person to become addicted. But a related problem is the fact that we've got Ohioans and people, I'm sure, in other states who aren't living up to their God-given potential because they're addicted, or usually, many times, they don't have the education. They do, as the professor said, they do not have the education. They do not have the set of tools to make it. And part of it is we do have to, I think, start saying to people, and we have to start, parents need to be saying, look, to their kids, we want you to live up to your full potential. Maybe you're working with your hands and you don't go to college, but maybe you go to, it's been said, an apprentice program or something else where you can become a welder or you can become a machinist and make a very good salary. So I think all of these things are tied into each other. And part of our challenge in Ohio and in other states, I think, is to focus on kids who are growing up, because it's easier to impact them than it is to, it's not that we're not going to try to impact someone older, but the kids are growing up, and make sure that they have all the opportunities that are there no matter where they're born and no matter what their income or who their dad is or who their mom is. And I think, to me, that's part of our solution as we look at the pain med problem.
Thank you. My time has expired. Thank you, Mr. Chairman, for your indulgence. I have some questions for you, Professor Deaton, for the record, about the economic impact of what you described. And I think the notion of opioids being an accelerant to what you and Senator DeWine just talked about is actually an apt description. Thank you, Mr. Chairman.
Thank you. The gentleman from Virginia is recognized for 5 minutes.
Thank you, Mr. Chairman, and thank all of you very much for being here. It's fascinating that it at least looks like a triangle in terms of there's the supply problem, as argued by General DeWine and Dr. Sacco. There's the economic dislocation, the hopelessness from Professor Deaton, and then the treatment side from Dr. Frank. So Dr. Frank, can you cite the reasons why those with an opioid use disorder would not seek treatment?
Yeah, about a little over half don't seek treatment because either they can't afford it, which is the biggest chunk, or there are no providers available to them. And so that's a little bit more than half. And then the other main reasons have to do with stigma in the workplace, in the community. And also there's a lot of people who deny that they have a problem. If I could take one other second, I just want to kind of clarify the issue around treatment, which is medication-assisted treatment is really the most effective treatment we have, but only about a quarter of the people who get treatment get that. And so we're undershooting our potential by a great deal, and that's what, in a sense, causes us to underachieve.
Thanks. You know, we have the Obamacare reform replacement repeal bill is in the Senate right now. I think Senator Cassidy said he wants to make sure it passes the Jimmy Kimmel test, which the House bill clearly didn't pass. But I'm hoping that, based on all that we're learning now, and Senator Portman talking about this is the worst addiction crisis in the nation's history, that whatever bill comes out of the Senate pass the opioid epidemic test. Professor Deaton, you said this really hasn't hit Europe yet. There might just be a temporary reprieve. Can you explain why the fentanyl from China and others hasn't affected that population, at least yet?
At least yet. I mean, that's for us, I guess it used to be the $64,000 question, now the $64 billion question. You can see some of this in the English-speaking countries of the world. You see some of it in Canada. There's a little bit in Britain and in Ireland and in Australia, perhaps a little bit in Denmark. And if you looked at those countries just by themselves, you would be worried about it. But when you put it in the context of the US, there's nothing happening there. Partly, I think it's because the prescription drugs are controlled much more carefully in Europe, and they're used in clinical acute settings, and they're not prescribed in the community yet. But I mean, there's a concern that they will spread out into the community. And I think the fentanyl thing, I don't know, but the black tar heroin, for instance, is coming from Mexico, and they have very easy targets here. And maybe fentanyl will come to Europe in the same way too. So I think the Europeans ought to be worried, and they ought to be, they ought to make sure that they don't get to where we've gotten to, and they want to be very careful about it, but we don't see the signs of this epidemic. And I think part of it is the control of.
Thank you. Dr. Sacco, you've been, looks like, studying this drug thing for many, many years, academically in CRS. And what did we learn from the crack epidemic that's relevant to fighting the opioid epidemic?
I'm sorry, did you say what did we learn from the crack epidemic?
Yeah. Are there lessons from the crack epidemic that are relevant here?
I'm not sure I can offer an opinion on that today. Okay. It's a little bit outside the scope of what I prepared for, but well, I'm happy to follow up with you. Is there anything specific to the crack epidemic?
Well, for example, we seem to have responded to the crack epidemic, for example, with lots of incarceration. We were pretty harsh about that. Mm-hmm. There's been a movement, bipartisan, in the criminal justice away from, criminalizing essentially nonviolent drug offenders or the harshness of it. Perhaps not with the Attorney General recently, but is that a solution here too? Or do we tilt toward the treatment side?
I can't advise one way or the other. I can certainly tell you that drug offenses account for the majority of federal offenses carrying a mandatory minimum. If that's what you're speaking to, mandatory minimums did come out of that era of the crack epidemic. There are different ways of looking at the efficacy of mandatory minimums. From an economic standpoint, research says that lengthy mandatory minimums are not cost-effective, and that other factors, such as certainty of arrest and prosecution, have a greater deterrent effect than the severity of the punishment. So in other words, a 1-year sentence likely has the same deterrent effect as a 10-year sentence. On the other hand, incapacitation prevents an individual from committing harm to society for that set period of years. At the same time, it is not clear if that punishment reduces crime. Often low-level drug offenders are easily and quickly replaceable.
All right, well, thank you very much. Mr. Chair, yield back.
Thank you. The gentlelady from Virginia is recognized.
Thank you, Mr. Chairman, and thank the witnesses for being here today. We've seen in my district, and I'm in Northern Virginia, here, just cross over the bridge here, and we have had a rise in MS-13 gangs as getting more involved now in trafficking of heroin and opioids. And so we're seeing this convergence of, very violent gang and then preying upon some very young people, both trying to recruit younger people into the gangs, but then also in getting them involved in these various things. What kind of effect are you seeing, anything like that? Are you seeing that elsewhere, or how that's going to impact the economy? And when we see these, particularly when you get these young people, that they're getting into these gangs, then it's a whole lifestyle, and that's how they're making a living. They're not getting educated, and it'll be even a worse situation.
Sorry, is that addressed to me? Or
Sure, that'd be
yeah,
great.
I'm not sure I can really answer that question. What I can say is that when we look in Ohio, our violent crime in our cities, a great extent of that is driven by gangs. And there is many times a connection between drug trafficking and the gangs.
And I know we've been focusing on the lower income and how we've seen the rise there. But I know we have seen in my district, we have very high, a lot of high income areas in this region, and we are seeing it hitting everywhere. So I did want to make sure today, even though it was focusing on that lack of opportunity, that this is, we are seeing this in every community and with every aspect. And so what is the difference when you're seeing, say, a college-educated kid who maybe just got addicted to these from a sports injury and then just, took it too far, and then they're in this lifestyle? What are you seeing the difference between, somebody like that versus, this expansion in a lower-income area?
Thank you,
Professor. Thank you.
I think income is not the best marker of this, partly because African Americans tend to be, there are a lot of low-income African Americans, and until recently, African Americans have been largely exempt from this epidemic. That does seem to be changing, and there is a tick up in the last 2 or 3 years in mortality of African Americans from opioids, and that may be fentanyl, and it may be spilling over into those communities. But low education has certainly been an issue. And what you say is true, that higher education people are suffering from this too, but nothing like to the same degree. I mean, this huge explosion has been among people with only a high school or even some college, but with the BA, it's much, much less. You certainly find people, for sure. It's everywhere. But it's throughout the community. I think also some of the standard protective forces from people have sort of broken down. I mean, one example I like to give is Utah has always been a very healthy place compared with Nevada, and for sort of obvious reasons. But Utah has not at all been exempt to this epidemic, and that's because, Mormons they don't drink, they don't smoke, they don't do things that are bad for your health. But when your doctor gives you pills, that is not something you're programmed to resist, and the church has not been very good at dealing with that. So
the education efforts that we were talking, the comprehensive approach that Senator Portman and others were talking about, and the Attorney General was talking about, really at that young age, kindergarten, and making sure education efforts really needs to go everywhere then.
But stop the docs pushing this,
so
that people know it's dangerous.
Yeah. Well, thank you. I yield back, Mr. Chairman.
Thank you. The gentleman from Illinois is recognized for 5 minutes.
Thank you, Mr. Chairman, for this hearing today and for this subject matter. And I want to thank the witnesses for your valuable testimony here today. I have seen the devastating effects of opioid abuse and heroin deaths in my own district. I represent a district of 19 counties in central and west central Illinois, a very rural district, and did a series of town hall events related to this issue with all the stakeholders, and it continues to be a problem. We've talked a little bit here today about some of the analogies to this epidemic, and we talked a little bit about crack cocaine. I spent 10 years as a state and federal prosecutor, and I think back to in Illinois 25 years ago, we had a real problem with drunk driving. It was the #1 killer in Illinois of young people. And so what happened? We had an aggressive law enforcement effort. We raised awareness, a lot of tragic deaths. But we also had Mothers Against Drunk Driving, which played a significant role from an organic level, kind of like what you talked about, Attorney General DeWine. We also use technology, ignition interlock. So today, we have some of the lowest levels of drunk driving deaths anywhere in the country. And that's because of an effort. And it was a movement at the time to do that. And I think about that analogy here today. The addiction is much different here, but we're able to reduce that problem and solve that in a variety of ways. And I think you have to, we've talked about this, holding everybody in the chain accountable. All the way through. And I'm not sure we're doing enough of that right now, and we've touched on some of those things. I don't know, Attorney General DeWine and then Dr. Frank, you want to comment on that?
Well, Congressman, I totally agree with you. This comes at the local level, comes at the state level. Certainly the federal government can play a role, but ultimately I think it comes back to the individual community. And you know, what we have seen in Ohio in this area is the communities that have started to make some real progress. Number one, admit they have a problem. Number two, there's a citizens group that's put together by a mom who's lost a son or lost a daughter, and they go out and they change the culture. Now, you still have a problem, but they make some progress. I saw it in my own career. I introduced a bill in the Ohio legislature, a drunk driving bill, and people were laughing at it. This was back in the early 80s. And it was the Mothers Against Drunk Driving who got it passed. Yep. And it just shows that, you know, it's the example I think we can all use with people. Look, you can make a difference. You can change the culture. You can change what people are talking about by a very active citizens group, either at the local level or at the state level or the national level.
Yeah. Dr. Frank, I may, you know, people also remember when we talk about drunk driving about, you know, the TV commercials that talked about these tragic deaths and highlight of just how horrific some of these were. And I'm not sure that we have had that level. And if we have, maybe there's some states or local areas that we can use as a success model on that.
Yeah. Yeah, I do want to offer a ray of hope because we haven't had much here today. And that is one area that we've been really successful on is in reducing the number of prescriptions on methadone for pain. It used to be that they were 6% of the prescriptions for in opioids and 30% of the deaths. And we've turned that around. And the way we've turned it around is, I think, by being very aggressive in training and educating of the physician community, making sure that our prescription drug monitoring programs really focused on that, and then CMS through the Medicaid program and through Medicare took measures to issue guidance to states and to do edits in the prescription drug plans under Part D. And together, they really brought down those prescriptions. And I think that, you know, in a sense, that is a reflection of the sort of multi-pronged approach. And I do think that that offers us a bit of hope here.
Yep. Professor Deaton, you touched a little bit on how we maybe hold doctors accountable and what we need to do. Is there, and much of that oversight on doctors and physicians is done at the state level. Is there an example of a state that has done a pretty good job in terms of holding doctors accountable?
I'm afraid I don't have an answer to that. We've done very little work on the geographical aspects of this epidemic, so I can't answer that. Thank you.
Okay. Thank you. Thank you, Mr. Chairman.
Thank you. Really appreciate all four of you being here. What great testimony we were able to hear today. I'm going to allow the acting ranking member, the gentlelady from New Hampshire, to have some final comments as well.
Thank you, Mr. Chair, and thank you all on behalf of Ranking Member Heinrich and myself for being here and for your testimony. And I just wanted to close with the thought of a particular constituent of mine who is now in recovery from heroin addiction. Because I think it's important, as we've had this discussion, to remember that ultimately this addiction is a disease. It is caused by a chemical reaction in the brain. And it is because people like my constituent Ashley, who woke up one morning to find her husband having overdosed and died next to her, went and got treatment under Medicaid expansion, that she has gotten well. And she now is working, and she's getting her health insurance through her private employer. She's off of Medicaid expansion. And I think it's really important that we also to acknowledge the comments we've had about the importance of community response, thank the people who have this disease, who have stood up, who have identified themselves as people suffering from addiction, have done the hard work of getting better, and then have turned their efforts to make sure that they help with the prevention and recovery efforts that we need to undertake. So I'm going to keep Ashley in my thoughts today. She's about 17 or 18 months in sobriety now. She continues to get treatment for recovery. She's going to be reunited with her 3-year-old son soon. There is hope if we go at this with all of the above approach. Thank you so much.
Thank you, Senator. Thank you again. There are stories like that we all can share. Attorney General DeWine has shared many with me as he's on the front lines. But I appreciate, and I think this entire panel, if you couldn't tell, appreciates the time you put into this testimony. You all complemented each other quite well. This is a battle that we're going to continue to fight in a comprehensive way, and appreciate the knowledge that you were able to share with us today, and we look forward to working with you in the future. The record will be open for 5 business days for any member that would like to submit questions to the 4 panelists for the record, and our hope is that you would respond as well. This hearing is adjourned.